Hello, everyone. We'll get started shortly. Welcome to today's webinar, Living with Metastatic Lobular Breast Cancer, Challenges, Treatment, and New Developments. I'm Kate Fitzer, Share's Metastatic Breast Cancer Program Director.
And I'm Jade Moran, Research Advocate.
Before the presentation begins, I'd like to tell you a little bit about Share. We're a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecological cancer and provides outreach to the general public about signs and symptoms. Because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our support lines, please visit our website at sharecancersupport.org.
Now, we have a few housekeeping reminders for you. All participants will be muted during the presentation. Once Dr. Shen finishes presenting, we'll begin a Q&A discussion. So please submit any questions through the Q&A section at the bottom of your screen. And remember that the speaker can't give specific medical advice. So please keep your questions general. Many questions were already submitted during registration, so thank you to everyone who submitted questions.
We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting the subtitle option. Lastly, this webinar is being recorded. In a few weeks, we'll share the recording with all the registrants and add it to our website. Now, I'd like to hand it over to Dr. Shen to introduce herself. The screen is yours.
Hi, everyone. It's such a pleasure to be here with you all today. And I just want to say thank you to Cher for inviting me to speak to you all. And I'm really excited to kind of engage in a discussion and answer your questions. So I'm Sherry Shen. I'm a breast cancer medical oncologist at Memorial Sloan Kettering, and I'm a co-lead of our lobular breast cancer program here, alongside surgeon Dr. Anita Momtani and pathologist Dr. Freja Pareja. So I'm really excited to talk to you guys about some of the updates, primarily in the last year or so, about metastatic lobular breast cancer, which I'll say as ILC for the rest of the talk, just for sake of ease. So let me share my screen. This always takes me a second.
Perfect.
Great. All looks good, right? Okay. So this is the outline of things I want to talk to you guys about today. I'll give some background on ILC to start. I want to share with you some results of a recent study that we did here at Memorial Sloan Kettering of a very large cohort of patients with metastatic ILC in terms of their genomics and the kinds of treatments that they received. I want to share some new data that just came out of this past ASCO meeting in June, looking at how we can use ctDNA monitoring in patients with metastatic breast cancer in general, and also a smaller study that's unique to metastatic lobular cancer. I'll share some data from our group last year on the effectiveness of Enhertu, which is becoming an increasingly popular and used drug that's specific to metastatic ILC. I'll talk about some new therapies that are recently FDA approved or likely soon to be FDA approved, and I'll focus on camizestrant and inavolisib. And then I'll talk about some of the relevant clinical trials that I think might be of interest to patients with metastatic ILC. And my main theme to today's talk, or the take home essentially, is that genomic or genetic testing of tumor tissue or blood, meaning circulating tumor DNA, ctDNA, is really critically important because it really can inform treatment options. So I think it's just a very, very important part of the course of metastatic ILC to get this kind of genetic testing frequently at the time of each point of disease progression, and maybe even more than that. I'll show you some of those data today, because detecting mutations or detecting kind of the evolution of the amount, the volume of ctDNA can really affect how we think of treatment and future treatment options. So to start with some background on ILC and the way it works, the disease biology. ILC accounts for 10 to 15% of all breast cancer diagnoses, and it's characterized by a loss in the function of this protein called E-cadherin. E-cadherin lives on the surface of cells, and it's responsible for attaching to other E-cadherin of other cells. So it's essentially responsible for anchoring cells together. And what's unique to ILC is that that E-cadherin function is lost, so that cells don't have to stick together. And that's responsible for the metastatic pattern of spread that we see in ILC, where because the cells and the growth pattern in general, where because the cells don't need to stick together, instead of growing into a lump or a tumor, these cells can grow more like in sheets or in single files or even as scattered cells. And it's not just E-cadherin itself that's important in ILC, but when other proteins that are associated with E-cadherin, when E-cadherin is disrupted, those other proteins go on to do other effects in the cell that help the cell to develop the capability to invade, the capability to detach from the kind of connective tissue membrane that cells sit in. So it kind of sets off this cascade of events that can lead to malignancy, essentially. There are many different subtypes of ILC as well. These are just the majority of the subtypes shown here, but there are even more. The classic subtype of ILC is responsible for the majority of ILCs. These next couple, alveolar, trabecular, solid, and mixed, are mostly defined by their growth pattern, where alveolar ILC tends to be these kind of low-grade tumors, low proliferative rates, and they kind of cluster in this loose pattern. Trabecular, they look like these rope-like strands you can kind of see. Solid ILC tends to have a little bit of a higher proliferative rate, and it grows in these solid sheets. And mixed can be a mix of ILC with some other histologies. And then these three, pleomorphic, histiocytoid, and signet ring cell, are defined a little bit more by what the actual cells look like. So pleomorphic cells tend to be very abnormal, disorganized looking. Histiocytoid cells tend to be these bigger cells. You can kind of see these bigger, like pink-ish cells with this cloudy appearance. And signet ring cells are defined by mucin buildup inside the cells, which pushes the nucleus, the kind of center of the cell, towards the side and causes that appearance of a signet ring, essentially. So I alluded to this, but metastatic ILC is associated with these kind of unique places of spread of the disease, which is due to that growth pattern of ILC. So this is an older study on the left here showing this, comparing ILC with IDC in terms of the places of metastatic spread. And I would focus on the parentheses, which show the percent of those patients. So, for example, the percentage of patients with bone metastases in ILC is higher. So in this study, it was 50% compared to 38% with IDC. The percentage of liver metastases is pretty similar. The percentage of lung metastases appears lower. The percentage of non-axillary lymph nodes appears to be somewhat lower in ILC. CNS stands for essentially the central nervous system, the brain. That is slightly lower, but probably pretty similar. But it's really the others here, which in this study, they show us others include these kind of atypical sites, the peritoneum, the skin, the pleura. The pleura is the lining of the lungs. The peritoneum is the lining of the organs in our gut. The ovaries, the meninges, which is the lining of the spinal fluid in the brain, the stomach, and kind of these uncommon sites. You can see this occurs at a really high rate in ILC, 34% as compared to 10% in IDC. And ILC here is comparing the number of metastatic sites compared to IDC. This is relatively similar. You can see the proportion of patients with one site is high. This is at the time of metastatic diagnosis. Two and more than two is actually not as common. Site meaning organ. This is a more contemporary study that was just published this year, again comparing sites of metastatic spread for ductal and lobular. And here what we're seeing is that in ILC, which is the light blue, you can see bone more common. Visceral meaning the visceral organs versus a non-visceral site. The brain, you can see this is relatively similar, a lower rate, maybe a little bit lower in lobular. The pleura, again, the lining of the lungs. The meninges and spinal cord, we know this is one of the sites that lobular cancers does like to go, and that's a little bit higher in lobular, a little bit higher in the skin, the bone marrow, the peritoneum, which again is that lining of the guts, and the uterus. Orbit is the eyeball, and other sites. So this is some of what we already know about the genetic mutations that are typically present in ILC tumors. So this is specifically showing in metastatic sites. So essentially biopsies of some area outside the breast, looking at ILC and the genetic characteristics of that specific metastatic site. And what we're comparing here is the percentage of metastatic ILCs that have this genetic feature compared to, in parentheses, the percentage of ductal cancers that have that same genetic feature. So going from top to bottom, HER2 amplification, which is associated with HER2 positive disease. We know that ILCs tend to be hormone receptor positive. There's a lot fewer HER2 positive ILCs compared to ductal, and that's essentially illustrated here in the genetic testing as well, whereas the rate is more like 7% in metastatic ILC, but in ductal it's higher, closer to 11%. You can see that BRCA1 mutations, when we say germline, we mean inherited mutations from mom and dad. Occurs at a lower rate in metastatic ILC than it does in ductal. It's actually very rarely seen, these BRCA1 mutations with ILC. BRCA2 mutations, on the other hand, are pretty similar between these. I'm going to skip over NTRK fusions, which are pretty rare, as you can see, but PIK3CA mutations are very common and are actually a little bit more common in metastatic ILC compared to ductal. And then high tumor mutational burden. This is a marker of sensitivity to immunotherapy. And the cutoff that we use is greater than 10. So you can see that that occurs at a much higher rate in metastatic ILC as compared to ductal. AKT mutations similarly occur at a higher rate. And HER2 mutations, so this is different from HER2 positive disease, but mutations in the HER2 gene itself occur at a much higher rate compared to ductal. ESR1 mutations, which is a mutation that is related to resistance to hormonal-based therapies, is pretty similar between the two. And PTEN loss is higher in metastatic ILC as compared to ductal. And each of these are listed because they have implications on treatment. We have ways of targeting things like PIK3CA mutations, BRCA mutations, TMB I mentioned with immunotherapy, AKT, P10, we can use the drug TrueCap, also known as capivasertib, for these types of mutations. HER2 mutations, I'll show you some data on in HER2. And ESR1 mutations, this is a field that's developing rapidly where we're going to have several drugs that target ESR1 mutations that are going to come to market soon. So this is part of the theme where I mentioned that this kind of genetic testing is so important because these mutations can be matched to FDA-approved therapies. So I want to share some data from our Memorial Sloan Kettering study that we recently presented at ASCO of this year, where we looked at our experience with patients with metastatic ILC. I just wanted to show you some of the characteristics of our cohort, which was a big group of over 600 patients. We've treated even more than that, but for inclusion in this study in particular, we required everyone to have that kind of deep kind of genetic testing on their tumor tissue because that was one of the points of interest. So about 2/3 of our patients included in this study had recurrent disease, meaning they had a stage 1, 2, or 3 diagnosis and then were diagnosed with stage 4, as compared to patients who were stage 4 at the time of diagnosis. 40% of our patients only had metastatic sites in their bones, and then almost 40% of patients had involvement of a visceral organ inside the body cavity. When we look at subtype, that you can see here that there's a pretty big percentage of patients with unknown subtype. That's because when patients are diagnosed with de novo metastatic disease, so stage 4 at the time of metastatic diagnosis, it can be hard to tell what kind of ILC subtype they have because the biopsy is not done on the breast itself, where the breast architecture is not really preserved. And because we included patients as far back as 2002, where sometimes this wasn't routinely reported on pathology. So among those that are known, classic is the most well represented in our cohort. And then most patients had hormone receptor positive disease, a smaller proportion with HER2 positive or triple negative disease. So this was the frequency of mutations that we saw among patients with genetic testing on tumor tissue at the time of metastatic diagnosis. CDH1 is the gene that's responsible for E-cadherin, which I mentioned is characteristic of ILC. So CDH1 mutation was seen in 76% of patients, which is pretty consistent with what's already been reported. It's not 100% because we know that there are other ways that the CDH1 gene can become inactivated that isn't just through mutation. And we've done a lot of that work here at MSK, trying to better understand those non-mutation cases. PIK3CA mutations I mentioned are very common, 45%. AKT and PTEN are common as well. So PIK3CA, there are now a number of medications that can treat tumors with PIK3CA mutations. AKT and PTEN can be treated by capivasertib, also known as Truqap I mentioned. ESR1 mutations can be treated by the drug Orserdu, also known as elacestrant, but there are more drugs coming to market. This is a ERBB2 is also known as HER2, and for this, there are combination drugs. There's also Enhertu itself that can treat this, and this is very frequently seen. And then tumor mutational burden high, which is a marker of immunotherapy, again, commonly seen in our cohort as well. So I wanted to describe, what these patients are getting treated with, essentially. So patients in our cohort, the total number of lines of treatment on average is 4, but you can see that there is a wide interquartile range. And then the number of chemotherapies that people get on average is about 2. The number of hormone-based therapies, this is limited specifically to patients with hormone receptor positive disease, on average is 2. The proportion of patients who got a CDK4/6 inhibitor, which is our standard first kind of treatment that we give, was 47% in our cohort. That's because this is a historical cohort, like I mentioned, that dates back to even before these drugs were approved by the FDA. But palbociclib was the most common one, followed by abemaciclib and ribociclib. The average amount of time that people got on a CDK4/6 inhibitor was 12 months, and the average amount of time before patients had to go on to chemotherapy was 26 months. The left side is just kind of showing what I just showed on the prior slide. This is just for comparison, but to look at what happens after a CDK4/6 inhibitor as well in terms of hormonal therapies. So everolimus is still a drug that we sometimes use in patients who don't have any mutations that we can target. About 50% of patients got everolimus after a prior CDK4/6 inhibitor. For alpelisib, which is an FDA-approved therapy that's aimed at PIK3CA mutations, about a third of patients had gotten that after a CDK4/6 inhibitor. And when we consider any PI3 kinase inhibitor, this might have been on a clinical trial, it's a little bit higher. So the time on treatment, regardless of when these drugs were given, on average was about 4 months with everolimus, and it was shorter, about 3 months with alpelisib. When we separate by the second treatment that people get after CDK4/6 inhibitor compared to then the third treatment that they get, the second treatment tends to be a little bit better and is associated with about 5 months before disease progression, and then is closer to 3 months when these same drugs are given as the third kind of treatment that people receive. We were interested in whether the specific subtype of ILC mattered long term. And it seemed like, at least in our cohort, that whether someone had classic ILC versus pleomorphic versus one of the other types, which are even more rare and constitute a really small group, that it didn't seem like that itself affected people's long-term outcomes. What did affect outcomes, though, is any of these specific mutations that were detected. So, for example, if a CDH1 mutation was detected, in all of these charts, the 1 is denoting that the mutation is present. The 0 is denoting that the mutation is not present. What we're generally seeing is that when the mutation is present, that generally is a slightly worse prognosis than if that mutation is not present. So, for example, with CDH1, PIK3CA, E10, and ESR1 mutations in general, if that mutation is detected, that prognosis is slightly worse. But that being said, in the modern day, we're developing more and more treatments that are specifically targeted to those mutations, and patients can only get that drug if they have the mutation. So I think that this over time is really changing rapidly. So I wanted to share some data on ctDNA that came out of the ASCO meeting. So when I say ctDNA, I mean circulating tumor DNA, which is DNA that's in the bloodstream that's detected from tumor cells shedding that into the bloodstream. So this is more easily detectable when patients have stage 4 breast cancer, because there are several different sites of the tumors themselves, and they're constantly kind of giving off some of this DNA into the blood that can be detected, both to measure how much is there as a quantification, and also what kinds of mutations are we seeing. So there's kind of two components to that. Signatera is one such ctDNA assay that really aims to measure how much ctDNA is there in the blood, and trying to correlate that with how much cancer is there in general is in the body. And can we use this as a way of understanding how the cancer is responding to the treatments that we give? So what we did in this study run out of MSK was that we looked at patients who had stage 4 breast cancer. This was not specific to ILC. This was kind of anyone with stage 4 breast cancer. We looked at a pre-treatment time point, which is labeled TP1 here, so before starting any treatment, and then looked at an on-treatment time point, meaning that patients started their treatment, and then at some point after they started, about 2 to 6 weeks, we checked the amount of ctDNA that was in the blood a second time. And we defined these categories as either seeing favorable dynamics, meaning a good change in ctDNA. A good change is defined as originally being able to detect something and now no longer being able to detect it, or just a decrease. Maybe we still detect it, but at least that number got lower, or someone who just stays undetectable, essentially. And then we defined an unfavorable dynamic as someone who was undetectable, but then we end up detecting some ctDNA, or someone who has an increase. So it was detected and then that number got even higher. And what we found was that in patients who had one of the favorable dynamics, meaning, it became undetectable, or at minimum it decreased, or it stayed undetectable, that the time to next treatment, so the time that they stayed on that same treatment that they started with, was longer. On the other hand, patients who had that unfavorable ctDNA dynamic, where the ctDNA actually increased, for example, then the time that they were able to stay on any given treatment ended up being shorter, because they ultimately develop disease progression on a scan. And we looked at this in terms of combination of an endocrine therapy with a CDK4/6 inhibitor. We looked at it with chemotherapy, and we looked at it as well with the newer antibody drug conjugates, and it held true across the board. So again, people who happen to have the favorable dynamic where the ctDNA gets decreased or undetectable are able to end up staying on their treatment for longer. But ctDNA is not perfect. We're not ready to substitute it for imaging quite yet, and I just want to show that here. In general, so this is on the x-axis of these graphs, we're looking at the tumor volume as measured on imaging. And in this direction, we're measuring the volume of ctDNA. And what this is really trying to show is that they do generally correlate pretty well. That's what this line is saying. So the greater the tumor volume on the imaging, the generally greater the tumor volume we're seeing in the bloodstream. But there are kind of these unique cases where in this group outlined in red on both these charts, these are people in whom we're not really seeing anything on the scan, but we're still detecting ctDNA in the blood. So what could be going on there? It could be just that there is true progression that we're not really capturing very well on imaging. This could be a real problem in ILC as we know the limitations of imaging, but it could also be for other reasons. For example, sometimes after radiation, it takes a long time for the ctDNA to go down. Or there could just be kind of this persistent low level that is just disease that's too small to see on the imaging. Then there are other patients in whom we're still seeing tumors, and yet their ctDNA level is undetectable. So that's shown in the green circles here. So in some of these patients, maybe that they're just having a really early ctDNA response, whereas the imaging is kind of lagging a little bit. Maybe the imaging is showing more dead cells and it's not actually a live tumor. And that's what the ctDNA is showing. Or sometimes there are some areas of the body, like the breast actually, that just don't shed a lot of ctDNA into the blood. And so maybe that's what we're not capturing. Maybe the patient is still having persistent or even growing disease in the breast, but that's not correlating with what's happening in the blood. So I really just show this to illustrate that we're getting better and better with ctDNA, but it's still not really ready to completely replace imaging because there are these kinds of unique cases where they don't correlate well. But I do think that we are going to start to integrate this more and more into kind of our overall picture of how people are doing on their given treatments. So this study was done by one of my colleagues, Dr. Foldy, which did look at ctDNA using that same kind of test, a Signatera test, and looking at it specifically in metastatic ILC. So I just wanted to share some of those data because this is a little bit more applicable to our talk today. This is just to show the characteristics of the patients. This was a small study. They included just 66 patients in this study. And just some of the things I wanted to highlight was that most of the patients had hormone receptor positive tumors. Most patients were getting hormone-based therapy or CDK4/6 inhibitor. Some fewer were getting chemotherapy. And then bone and or the gastrointestinal sites were the most common sites of involvement. And then less in the lungs, the liver, and skin. So this is what they found here. I don't think the y-axis of this graph is necessarily so useful because it's just the number of patients, but I think the percentages are more helpful to focus on. So what they're showing is that most people with metastatic disease, the ctDNA is detectable prior to treatment. So they're showing here in patients even who have just disease in their bones or just in their gastrointestinal tract, that still 93% of patients have detectable ctDNA. And if it's in the lungs, liver, skin, bladder, nearly 100% of patients have detectable ctDNA. And what was really interesting that they showed is that, again, this correlates with whether or not someone is going to get benefit or progression on their given treatment type. So, what this is showing is essentially this group of patients, the ctDNA increased. So, this is a change of an increase in the ctDNA level. And then this is the group of patients that had a decrease in their ctDNA level. So, decrease is good. And you can see that in the patients who had an increase, most of them are denoted in red, which is that they unfortunately had disease progression on that given treatment. Whereas in these other patients who had a decrease in their ctDNA level, those are the patients that tended to get clinical benefit from the current drugs that they were on. So it does look like even in metastatic ILC that the ctDNA probably does track reasonably well with the amount of disease. And this was just showing the positive predictive value and the negative predictive value of each of these tests. Positive predictive value, which is shown on the left, is defined as the likelihood that a positive test, meaning a detectable ctDNA, means the person actually does have detectable and worsening disease. And the more time since that test was done and showed a detectable result, the more likely it is that that does impact upon their disease progression. And then the negative predictive value is the probability that a negative test or an undetectable test means that the person actually has undetectable or favorable disease characteristics. And this is just saying that with more time, that likelihood actually decreases because probably with more and more testing, they're going to end up detecting something. And then in this paper, Dr. Foldy wanted to illustrate two specific patient cases that can show us how we can use ctDNA measurements in clinical care. So this is a patient who initially started on letrozole and abemaciclib. And in black is the ctDNA, and in brown is the tumor marker. So what you can see is that with the ctDNA, they went on a treatment break from abemaciclib due to side effects, and the ctDNA jumped up. Then they went back on the abemaciclib, and the ctDNA went down. But then at some point, it went back up again, and that's when they saw disease progression, which is denoted in the red triangles. And that's when they went on to go to a different treatment. This is a different patient case here where they started on letrozole and palbociclib. And you can see that initially the ctDNA had a nice response where it went to completely undetectable, but then started rising. And this is the time point at which the imaging showed disease progression. They got radiation and they started on a new drug. They ended up having a specific mutation, ESR1 detected, and they went on to get elacestrant, and then the ctDNA went down really nicely to undetectable again. Eventually, the ctDNA goes up, and that correlates with the disease progression on the scan. And then they switch to a new treatment, and then it goes back down. So this is kind of generally what we expect to see with ctDNA, where it goes up, it goes down, in conjunction with probably overall what's happening on the scans. So I wanted to share some data on Enhertu in metastatic ILC. So this was a study that we presented late last year, and Enhertu is becoming increasingly used for what's called HER2-low disease. That is to say, patients with technically HER2 negative breast cancer, but there's shades of gray essentially, where most people aren't true negative, meaning zero HER2 detected at all. Most people have a small amount of HER2, not quite enough to be labeled HER2 positive, but still a small and detectable amount. And that amount is generally enough for a drug like Enhertu, which finds any amount of HER2 that exists. And it's an antibody drug conjugate that kind of delivers chemotherapy directly to the cells in which there is that little bit of HER2 and can actually kill some of the neighboring cancer cells as well. This is a busy slide. We don't need to go through this in detail. This is just to show that it was a relatively small cohort that we had, metastatic ILC being treated with Enhertu. Most of these patients had hormone receptor positive disease, but we did look at some patients with triple negative breast cancer as well. So triple negative metastatic ILC specifically, who had HER2 low disease to get Enhertu. And a lot of these patients actually had PIK3CA mutations, for example. And then in terms of the average number of doses of Enhertu that people got, it was typically around 11 for hormone receptor positive and around 7 doses for the triple negative group. And most patients had to discontinue taking it due to disease progression and not actually due to toxicity. And there were a group of patients in our cohort who were still taking Enhertu kind of in a more longer term way. So the average amount of time that patients in our study with metastatic ILC got out of Enhertu was about 7 months' time. And then when we looked at people with HER2 mutations, so remember HER2 mutations are one of those mutations that are more common in metastatic ILC than in ductal disease. What we saw was that patients who had a mutation actually got longer time out of HER2. So that was really interesting and promising. And that's why that kind of genetic testing is really important because it might mean that you could get more benefit out of a drug like HER2. When we separated that further to look at if people had gotten any other prior antibody drug conjugate before or not, and whether they had a HER2 mutation, people who got HER2 as the first antibody drug conjugate and also had a HER2 mutation tended to do really well. This was looking at people with PIK3CA mutations. People with PIK3CA mutations seem to get less time out of HER2. And again, this was looking at just overall prognosis with the HER2 mutation. It seems like in terms of overall with other treatments in general, that it didn't necessarily affect prognosis, but specifically the disease response to HER2. So next, I want to share some newer data. These two studies that I'm going to talk about are not specific to metastatic ILC, but are relevant because they're specific to hormone receptor positive metastatic ILC. And these two studies are really going to kind of change the way that we think about treating some of our patients. So this was a trial with the drug camizestrant, which you can kind of think of as a newer generation pill form of Faslodex injections. And it's specifically for people with ESR1 mutations. So what they did in this study was for patients getting their first kind of metastatic treatment, which is usually a drug like anastrozole, letrozole, or exemestane in combination with a CDK4/6 inhibitor, which is palbociclib, ribociclib, or abemaciclib. These patients underwent routine ctDNA monitoring to see if they develop an ESR1 mutation, which is a hormone resistance mutation. And then in the people who end up having it detected, they went on to get enrolled in this study. So this study was for people who develop an ESR1 mutation, which confers resistance to the drugs like anastrozole, letrozole, and exemestane. They got randomized to either getting camizestrant, which can target the ESR1 mutation, and continuing their CDK4/6 inhibitor, versus continuing on their aromatase inhibitor and the same CDK4/6 inhibitor, and then eventually switching when the scans showed disease progression. So this was essentially a trial that tested switching right away when something is detected in a ctDNA test, as opposed to waiting until the scan shows change and then switching the drug. And what they found was that early switching, meaning switching to this new drug when the blood-based mutation, ctDNA, was detected, was associated with a longer time until the next time that imaging showed disease progression. So I think this is a really interesting study in that, first of all, camizestrant is a good drug. Like I said, this is a oral pill version of Faslodex injections, so it's pretty well tolerated, and certainly not having to come in, monthly for injections can be really helpful. So it firstly showed us that this is a good drug, but second of all, made us really think about, if we should be doing these kinds of ctDNA monitoring tests and changing treatment based on that result alone and not necessarily waiting for a change in the status of the disease based on imaging. I do think this is still a little bit controversial. We have to wait for longer follow-up because the question is, well, if we switch at the time that the disease is growing on scans, could we essentially catch up, basically, catch back up in the time that was gained from switching early? And we don't know the answer to that question quite yet. But we do know that this is a really good drug, and we'll await the FDA decision on this drug. So this is not yet approved for use. A drug that is approved for use is this drug called inavolisib, which targets PIK3CA mutations. So this was a phase 3 study that was done in patients specifically who had a PIK3CA mutation and who developed their stage 4 disease while they were still taking hormonal therapies or were shortly, like within 1 year of stopping their hormonal therapy that they had been taking for stage 1, 2, or 3 disease. So it's essentially looking for patients who develop a relatively quick recurrence while they're still taking drugs. And again, a PIK3CA mutation was required. And this randomized patients to either getting inavolisib in addition to their Faslodex and their Ibrance, palbociclib, or just getting Faslodex and Ibrance. And what this study showed was that adding in the inavolisib, so making this a 3-drug combo as opposed to a 2-drug combo, and targeting that PIK3CA mutation as the first kind of treatment that someone gets for their stage 4 disease, was associated with a lot longer time before a change in treatment was necessary. So this is certainly a really interesting combination. It does have a lot of side effects because it's 3 drugs as a combination. So that's one caveat. It's not appropriate for everyone across the board, even not necessarily for everyone with a PIK3CA mutation, but it's something that could be considered for some patients. And lastly, I just want to highlight some ongoing clinical trials that might be very relevant to patients with metastatic ILC. This is a trial that we're doing here at MSK. This is for patients with hormone receptor positive, HER2 negative metastatic breast cancer in general who have had a CDK4/6 inhibitor before and developed disease progression. You can have up to 2 prior lines of chemotherapy for metastatic disease. Measurable disease is required, which can sometimes be a limitation for patients with metastatic ILC, which isn't always necessarily so clearly measurable on scans. So I do acknowledge that. A biopsy is required, and then patients get this drug called lenvatinib, which is not currently FDA approved for breast cancer, but it is FDA approved in some other disease types. Lenvatinib is a drug that can work on the blood vessels that tumor cells co-opt to feed themselves, nutrients and oxygen. And it can actually kind of prime the immune system and get it ready for immunotherapy. Then we add in Keytruda, also known as pembrolizumab, which is an immunotherapy once the immune system has been primed. We know that immunotherapy in general doesn't tend to work that well in hormone receptor positive disease, but I raise this for metastatic ILC because, as I showed, that tumor mutational burden, which can be a marker of sensitivity to immunotherapy, having TMB high occurs at a higher proportion of patients with metastatic ILC than ductal. So this might be a relevant clinical trial for people who have high TMB, for example, but we're actually not requiring that. So even patients who don't have high TMB can enroll. And the idea is that this drug lenvatinib is going to help the immunotherapy work better in hormone receptor positive disease. Another clinical trial that has ongoing enrollment that I want to share is called REPLOT, which is being conducted out of MD Anderson by my colleague, Dr. Mwabi. This is also for patients with hormone receptor positive metastatic ILC who've had prior endocrine therapy and CDK4/6 inhibitors. This study includes kind of a safety run-in period to just confirm that these drugs are safe and don't cause unwarranted toxicity. And then patients are enrolled who have never had Faslodex before, and they go on to get this drug called repotrectinib in combination with Faslodex. This drug targets something called ROS1. There's been some data showing that loss of E-cadherin, which is again that hallmark of ILC, can result in the tumor cells being really, really dependent on ROS1. So then we could hit it with an anti-ROS1 drug, essentially. That's the theory behind this. So this is such drug in combination with Faslodex or fulvestrant injections. And then eventually they'll also enroll patients who've had fulvestrant before and give them this drug. I will say at San Antonio last year, we heard the results of the Rollo trial that tested a similar drug called crizotinib. And unfortunately, the results of that trial were quite disappointing. It actually didn't seem to work that well in patients with metastatic ILC. But the difference here is that repotrectinib is a better drug than the drug that was tested in the Rollo study. So even though it's kind of a similar class of drugs, a similar way that it works, repotrectinib does seem to be the better, stronger version of that drug. So we're hopeful that we might still see good results here. And then I mentioned a couple of these newer pill versions of Faslodex injections, of which only one is available currently and is only approved for use on its own, not as a partnership with other drugs. So I think that that has some limited usefulness as a result, and it hasn't shown very good success or very long time on that. So, one phase 3 study that I wanted to highlight is called Elaine 3. This is for patients with an ESR1 mutation. So, essentially, this is a chance to get a new kind of hormone therapy that's targeted to ESR1 before this next set of drugs ends up being FDA approved. This is for patients who are on an aromatase inhibitor and either palbociclib or ribociclib, and they develop an ESR1 mutation, and they're randomized to either get lasofoxifene, which is a new hormone therapy, versus Faslodex injections in combination with a different CDK4/6 inhibitor, abemaciclib. And lasofoxifene has looked very promising in earlier studies and really importantly is very, very well tolerated. So this study is a phase 3 study and will hopefully lead eventually to FDA approval of lasofoxifene. So this study is enrolling nationally and might be enrolling at a site near you. And then the very last clinical trial that I want to highlight is a estrogen-directed PET scan trial that we have here at MSK. So we're seeing increasingly from studies that estrogen-directed PET scans might be better at detecting metastatic lobular disease specifically as compared to standard PET scans, which are called FDG PET scans. So this is a study we're doing where patients are getting kind of their standard of care hormone-based therapies, whatever their physician wants to give them. And they get an FES PET scan at baseline before they start that therapy, and then about 3 to 4 months in, so that we can really look at disease response. We currently typically don't use these estrogen PET scans as part of monitoring disease response, but we're trying to better understand if this is a good way to look at response to treatment, if that's an appropriate way to use these scans, and if we can compare them specifically to standard FDG PET scans in looking at the number of spots that are detected on that kind of imaging and hopefully show that these estrogen directed PET scans are better at picking up lobular disease and might become more standard of care for patients with metastatic ILC. So with that, I'll end. I want to leave time for questions. I just wanted to say thank you very much for listening. Thank you to all the patients and their families who join research studies and are part of our research and helping us better understand this unique subtype of breast cancer and better understand how to develop the next generation of treatments for this disease. I wanted to particularly thank our funding sources, Conquer Cancer, the ASCO Foundation, Terry Broder Breast Cancer Foundation, the Lisa Boncheck Adams Memorial Fund, the LBCA, which has not only provided some research funding, but also has been an amazing advocacy group to work with. And thank you to GRASP for selecting some of our research this year for an Advocate Choice Award. And of course, thank you to you guys at Share, as always, for getting the word out and for organizing these. So I will stop there and take questions.
Thank you so much, Dr. Shen. That was fantastic. So we have been getting a lot of questions, either pre-submitted or today. And so a lot of them, of course, have been about diagnostics, imaging and blood-based tests like ctDNA, which you've explained so love beautifully. So I think a lot of patients will relate to this first question, which is, why is it so difficult to identify metastatic lobular breast cancer on standard scans? And what's being done to improve detection? Are there better, imaging tools being developed? I
Yeah,
answered that a
absolutely.
little bit, but sort of expand on it, perhaps. Thank you.
Sure, of course. So the way a standard PET scan works, the FDG PET scan, is that it depends on how quickly the cells are growing and dividing. So essentially, when you go for that kind of scan, it's a sugar solution, glucose, tagged to a radio tracer. And every single cell in the body consumes sugar, including the brain, the liver, every cell feeds on that. But cells that are very active, like the brain and liver, which have a, big job to do in our bodies, but also cancer cells that are very active, take up more sugar than the tissues around them. And that's how we see them on these FDG PET scans. But we know that lobular breast cancers tend to not be that rapidly dividing. They can be kind of slower dividing, more insidious, but also spread quickly because of that not needing to grow into a tumor. So it's like essentially because of the biology that they might not be captured well on FDG PET scans. FES PET scans, which I mentioned, we have a study for, but are actually, you can obtain them standard of care too. It doesn't just have to be on a research study. Um, Not every institution is equipped to do this, I will say, nationally, but the company is expanding their kind of reach across the United States currently. But FES PET scans might be particularly helpful in hormone receptor positive ILC. So that's very specific. It's not really to be used in triple negative or HER2 positive disease because it's looking for estrogen. But for hormone receptor positive ILC, it really hones into anywhere that estrogen is needed in the tumor cells. So it can kind of pick up better. There have been several studies now that directly compare regular PETs to FES PET, and FES PETs just pick up more spots of disease in lobular cancer specifically. And just this year, the NCCN guidelines, which are kind of like our guidebook to practicing oncology, if you will, was updated for breast cancer to now include FES PET specifically for patients with lobular breast cancer in whom we're suspecting or worried about stage 4 disease. So this is patients with high risk early stage, maybe there's lymph nodes involved or the tumor was really big. These are patients who should now be able to get this estrogen directed PET scan as standard of care and have insurance coverage, which was a huge win this year. So there's other types of scans being developed in research. So I think there's a lot of work to be done here, but at least we've had one really good step forward with using these FES PET scans. There are a couple caveats, like I mentioned, the hormone, component being one of them. There's also some drugs that interfere with how it detects disease. So that's another caveat. And we also really need to learn about if it's appropriate for disease monitoring. So we don't typically do this like multiple times. It's kind of at these diagnostic time points to help us better understand where the cancer is.
Thank you. We have sort of a follow-up related question to that, which is that it's about variability between patients about the efficacy of imaging. So why a scan that works for one person won't work for another, and how do we, as individual patients, know if we are being monitored with an imaging type that is accurate for us?
That's such a great question. And I think this just gets to, the more we learn, the more we're able to personalize our treatment plans for patients. There's no one size fits all. There's no one right way to go through treatments. Everyone is so different, right? Just starting with like patient characteristics, age, menopausal status, that sort of thing, but also tumor characteristics. There are metastatic ILCs that do have a high proliferation rate. For example, some of the triple negative ILCs, or there are some, like I said, that just have a high Ki-67 level or might not be that hormonally sensitive in general. Those are the kinds of tumors that tend to be well represented or detected on a standard PET scan. On the other hand, I would say, and I see this a lot with, my own patients that I treat, there are patients in whom the PET scan doesn't show anything, but I'm worried, right? They might have high risk disease. They might have some symptoms like back pain or something that I just feel like, you know what, maybe that scan's not the best one. I might get an FES PET scan or even just a standard CT chest, abdomen, pelvis that, gets a little bit of a finer look at some of these, like essentially finer slices of the body, if you will. And if we pick it up there, then that's the kind of scan that I favor in that patient going forward. So, like if something is not seen on an FDG PET, but is seen on the finer detailed CT scan, then I will go with CT scans going forward because that seems to be better for that patient in particular. On the other hand, if things were well detected on the FDG PET, then I'm very comfortable using that for every response, essentially.
Okay, thank you so much. I think Kate was had some questions about the ctDNA, which a lot of you
Yeah.
covered, but and Kate from the audience had a lot of questions, but some of them have not particularly been covered. So, Kate, do you want to ask those?
Yeah, so you had mentioned a lot about the ctDNA. Um, and you were talking about maybe it's not quite ready to be used in replacing the scans.
Correct. Yeah.
Um, but because we're hearing what we're hearing now is that the scans can be it can be challenging for patients that are diagnosed with ILC. Can you use them at the same time? So can you use them uh
Yes.
do you use them every 3 months, or what would your advice be or recommendations for that?
Yeah, and I would say that this is something that's rapidly changing, and that I even was someone who did not regularly use ctDNA all the time, like every 3 months as monitoring. I was kind of using these tests at times of treatment change. So essentially, when there's disease progression, which I've seen on imaging, I've been getting a ctDNA test to see what are the mutations that have emerged. Are there new mutations that I can target now that have evolved as resistance of treatment? So I was really primarily using these only at times of disease progression. But I would say in the last year is when we're really in the last few months is when we're seeing more and more data that suggests that we can use this as monitoring just how much disease there is in conjunction with scans. You can definitely get them at the same time points as scans. I would say at this moment in time, I don't feel comfortable completely replacing scans and just saying, you're fine as long as your ctDNA is fine. We'll just scan you if things change. Because of those kinds of unique circumstances, we're still developing better ctDNA assays that can detect even tiny, tiny amounts of DNA. We don't want to miss anything. So I currently now am starting to think of it more as one additional piece of information that can integrate together with all of these other pieces of information, like what do the other blood tests look like? How does the patient feel? And what does the imaging look like? And put it all together as one big piece of what is the status today of the cancer? What do things look like? Do it looks like things are generally responding nicely? Is there one spot that's being kind of finicky and, maybe the imaging isn't showing it, but the ctDNA is rising, or the opposite? Maybe we're seeing one spot on the imaging, but that seems to be growing. But luckily, the ctDNA is stable and it's not increasing. Maybe let's just use some radiation and target that one area. So I kind of think of it as now integrating into part of the package. And I think I will start to use this more and more. But overall, I'd say most people, we haven't adopted this quite yet as to frequent monitoring. We're just getting more and more data showing us that it is going to be a very important part of our treatment plan going forward.
Mhm. And
Um,
does insurance typically cover that?
Great
What are you seeing?
question. Great question. Certainly at times of disease progression, insurance definitely covers it because it's associated with some of these newer drugs. So, for
Mm-hmm.
example, like the ESR1 mutations, there's a drug that's FDA approved for it. And so they incorporated that kind of ctDNA testing to detect that mutation in the clinical trials that led to FDA approval. And as a result, that test is part of the FDA approval as well. The every 3 months, I would say, is a lot more variably covered and is also part of why it's not so easy to adopt it in every patient across the board.
Hmm.
Um, I think in general, Signatera testing, the company has been pretty good with helping with coverage, even when insurance doesn't cover it. But this can be a bigger problem with the more frequent monitoring, certainly. At times of disease progression, it's covered.
Okay, that's good to hear. So we
I
have
have
one question that's live, one that she's this uh, we're asking about the various mutations that you discussed.
Mhm.
Are they based on the original metastatic tumor biopsy or later on in the metastatic process? And how is that detected?
Great question. Great question. The For the drugs, the FDA approved drugs, we can use a mutation that's detected at any time. But I do think, upon stage 4 diagnosis, a biopsy is being done anyway. Biopsies we need because they confirm the estrogen, progesterone receptor, and HER2. You can't get that from ctDNA. So that biopsy has to be done at stage 4 diagnosis. I would say it's important to run the genetic testing on that biopsy sample, but you can do ctDNA at the same time. There's pros and cons to both. One of the pros of the tissue biopsy is that it can it doesn't depend on how much cancer there is because it's targeted the tumor. There's going to be enough cancer cells to test. But the con is that it's just one of maybe many spots of stage 4 cancer, right? And they may all be a little bit different. So ctDNA takes what's in the blood, so it can actually capture what different sites of disease are shedding into the bloodstream. So it might give a
Mm.
more comprehensive picture, but on the other hand, it depends, being able to detect a mutation depends on how much circulating tumor DNA is shed into the bloodstream in the first place. So if there's not much, you're not going to find any mutations. That doesn't mean the cancer doesn't have any mutations. Does that make sense? So I don't see them as one or the
Mm.
other. I think they're both super useful at the time of metastatic diagnosis. Then at times of disease progression, it's not always feasible or reasonable to just keep getting biopsies, right? We don't want to put our patients through like 5 different biopsies.
Right, right,
There are some circumstances where, especially where it seems like hormonal therapies are no longer working, that we do want to get a biopsy to better understand has it become triple negative, for example. But it's at those time points, especially where we're not getting biopsies, that ctDNA is really critically important because that's where it's looking for those new mutations, but we're not getting a new form of tissue to test it on.
right. Okay. Thank you so much. We are at the conclusion of our webinar. So thank you so much, Dr. Shen, for your thoughtful and your thorough answers to all of our questions today. And thank you everyone that joined us today. We'll have a recording of this program. It'll be available on our website in a few weeks. So please check Share's website for upcoming educational programs and support groups. Don't forget to follow us on social media as well.
Thank you so much, Cher, for having me today. And thank you everyone for joining and listening.